Okay, it looks like we're getting a quorum here, so let us begin. Good morning to everyone. I'm John Fitzpatrick, Community Health Strategist from KC Digital Drive. We've got a really nice lineup today for you, dealing specifically with women's health. First, we'll hear from Dr. Kim Templeton about advances in dealing with menopause and the possibility of applying AI. And then we'll hear from Mariah Kranz about the idea of data sharing for mother and child health. Um, Let us just kind of first picture who's around the table with us so the presenters have a good idea of who their audience is. So I'll invite everybody to introduce themselves. I'll call you out and have you just say a word about yourself. Um, First, let's start with Doug Hohulin.
Hello, I'm Doug Hohulin, and I'm on the advisory board of KU School of Nursing, also author of Tech-Powered Healing, the Future of Healthcare in the AI Age, along with Dr. Harvey Castro.
Great. Elizabeth Crocker.
Hi, I'm Elizabeth Crocker. I'm the CEO of Emerald Venture Partners, and we are an advisory and services firm to health and life sciences innovators and investors.
Great. Thank you. Chris Fernacci.
Hey there, good morning. I'm Chris Vernacci. I work, this is actually my first call attending. I work for a digital health tech company located in Kansas City called Heart, and I'm also a board member of a nonprofit called First Call that is focused on substance abuse and awareness education.
Oh, that's great. They are somewhat of a partner of ours, so that's good to know.
Okay, great.
Yeah. Uh, Dr. Castro.
Hi, can you hear me?
Yes.
Okay, good. My name is Dr. Castro. I'm an ER doctor. Been doing it for about 20 years. Have my own AI company that I've been creating different applications. So great to be here. Thank you.
Great. Thank you. Jill Watson.
Hi, I'm Jill Watson, and I work at North Kansas City Hospital. Been active on a number of boards and peripheral to the IT community, really, but very interested in healthcare innovation.
Great. Marlene Nagel.
Good morning, Marlene Nagel. I'm Community Development Director for Mid-America Regional Council and work with a lot of organizations around healthcare and public health. Thanks for including me.
Yeah, sure. You're very welcome. Tapan Bhatt, are you with us? I think he's just note-taking. Anurag.
Good morning. Sorry, I couldn't find the mute button. My name is Anurag Patel. I'm co-founder, CEO of Abada Health, and I also help here with the Digital Drive Health Innovation team.
Thanks. Cecilia Saffold. Cecilia, are you with us? May have just stepped away. Krista
I'm
Hahn.
sorry. I'm
Oh,
sorry,
okay.
John.
Go
I
ahead.
was searching for mute. You know how
Okay.
that goes.
Yes.
Cecilia Saffold, CEO of Health Teamworks. We're a healthcare quality improvement and transformation nonprofit. We work nationally and have a significant footprint in the Kansas City metro.
That's great. Thank you. Krista Hines.
Hi there, good morning. Krista Hines. I'm a health and wellness writer with an interest in women's health, particularly in the new innovations that are coming out with women's health and femtech.
Great. Dan English.
Good morning, everybody. Dan English here, KU School of Nursing. What's my job? Cancer clinical research coordinator / program coordinator / project coordinator. So I do a lot of jobs at KU School, KU Med Center.
Okay, great. Deb Cisco.
Good morning, everybody. I'm Deb Cisco. I'm the manager for patient advocacy and engagement over here at University Health.
Great. JD, Dr. Tyler.
Yep, same problem as everybody else. Yep, JD Tyler, CEO and founder of Just Ask Evie. We provide real-time virtual elbow support for physicians and nurses, as well as a platform for health systems to optimize their internal team, along with workflow analytics to help alleviate physician and all clinician burden and burnout.
Great. Jeff V.
Hello, everybody. Jeff Van Reagan. I'm in digital health for a little over 10 years on the business development side. I'm here to network and learn about the latest innovations coming down the pipe.
Thanks, Jeff. Derek Madge. Derek, you still with us? Okay, let's go to Jenny Marshall. There's Derek. Derek, do you want to say hi? Maybe not. Jenny Marshall, are you with us?
Yes.
Go ahead, please.
Yes. Can you hear me? Sorry.
Yes.
I was going to go ahead and let him go if he had jumped on. So hi, everyone. I'm Jenny Marshall. I work at Children's Mercy, and I am part of Strategy, Innovation, and Partnerships. And I work a lot in feasibility and strategic outcomes. So I'm very interested in projects in their initial stages and trying to help them move forward, especially investigator-initiated studies and local work that's being done.
Great. Jim Ondick.
Yeah, good morning. An IT business partner at University of Kansas Health, Health System.
Jim Starsiv.
Jim Starsiv, part of the KC Digital Drive team.
John Birch.
Hi, thanks. This is John Birch. I live in Lawrence, Kansas. I'm a part-time, I do some angel investing, a member of the Mid-American Angels, but my interest in this topic here today is primarily connected to my involvement with this think tank called the Health Record Banking Alliance, which is focused on exploring whether there is yet an ecosystem sufficient to support personal health records, and I mean really good quality longitudinal personal health records. This is of particular importance for maternal care, which is certainly one of our topics today, in that maternal care overlaps with not one but two lives, and so allows you to start creating a health record for the newly born children that they can keep for their entire lives. So these are a variety of questions and topics related to that are of interest to me.
Great. Thank you, John. Josh Weimer.
Hey, absolute privilege to be here with the group. I'm honored to be the Chief Health Information Data Strategy Officer for Missouri Department of Health and Senior Services. And I won't bore you with the other things on my resume. Would love to connect on LinkedIn. But I did want to say to Dr. Castro, he did put a link in there for Stephen Ferrero's initiative at Columbia, and I could not recommend that more highly to the group.
Great. Dr. Templeton.
I'm Kim Templeton. I'm a professor of orthopedic surgery and associate dean at the University of Kansas, and also past president of the American Medical Women's Association.
Thank you. Liz Willenborg.
Good morning. I'm Liz Wellenborg. I'm the telemedicine manager at Children's Mercy in Kansas City.
Mariah Kranz.
Mariah Kranz, Programs Director here at Community Health Council of Wyandotte County.
Nanette McLean.
Good morning. I'm Nanette McLean, Vice President of Behavioral Health at Concerto Care, a medical group that delivers home-based medical care.
Great. Ross Noakes.
Yeah, good morning. Ross Noakes, Vice President for Acuity Health. We are a telehealth organization that provides virtual nursing, virtual telemetry, virtual sitting, and even intensivist virtually through tele-ICU models. Thanks.
Okay, thank you. Sherry Tauheed.
Good morning, everyone. My name is Sherry Tauheed. I work with Metropolitan Community College.
Great. Steve, is that are you with us?
Steve Sewell, sorry about that. Didn't pop up the way I thought it was going to. Good morning, John. Thanks for doing this. Hello, everybody. I'm a consultant in the digital industry, Chief Revenue Officer, Commercial Director, fractional on the left. Thank you.
Great. William Crumpler.
William Crumpler, part of the KC Digital Drive team.
Great. Is there anybody that I've missed? Okay. With that, let's go ahead and get started. I'd like to invite Dr. Templeton to share with us her experience of the national conference that was held by the National Science Foundation to look at applying AI in the treatment, or the treatment's not the right word, I apologize, in the care of menopause. I'd like to let her just kick off. Go ahead, Dr. Templeton.
I appreciate that. And I have a PowerPoint put together. I can do that, or I can just talk. It's whatever the will of the group is.
Well, PowerPoint's fine. You just need to share your screen.
Okay. All right. And I was going to start off with some just discussion of sex gender differences in general, which is part of the issue I think that we run into when we're looking at AI. There we go. If we're looking at use of AI, whether it's looking at menopause in particular, as this conference focused on, or if we're looking at women's health in general. And I think, in my opinion, the conference was not only to talk about menopause, but really to look at the larger view of women's health. And so when we're looking at women's health, it's beyond the traditional, what has been called bikini medicine. So it's beyond reproductive health or breast cancer. It's looking at every condition that women and men can experience, and then what are the differences in how those experiences can play out. Those are impacted by both sex and gender, as defined by the Institute of Medicine more than 20 years ago. Every cell has a sex. But sex and gender are different, although related concepts. Sex is the biologic component, initially defined as gonadal, but now we look more at chromosomal complement, whether one is male, female, intersex, or otherwise. Whereas gender are the social interactions, the available resources. Are you able to access the healthcare system? Do you know how to? Is it a condition for which you would think you need to access the healthcare system? And that's whether you're woman, man, cis, transgender, et cetera, et cetera. There is also the emerging field of epigenetics, in which we understand that the environment can actually influence how genes are expressed. So there actually is a direct biologic influence of gender on sex. And the reason I go with this, starting off with this, is that to understand the health of both women and men, we need to understand that there are influences of both sex and gender, because that impacts what we could do in terms of research, which then impacts patient care. So what are sex differences, anatomy, physiology, effects of sex hormones, both local and systemic, but it's not only that. And then gender, again, is environmental influences, social interactions, personal experiences, ability to access the healthcare system, how that interaction plays out. All of these impact the risk factors for conditions, incidence, presentation, response to treatment, and prevention. So some sex-based differences, we know there are differences in pharmacokinetics and pharmacodynamics, meaning women aren't just small men. There are differences based on body weight, but it's more than body weight. Women have a higher proportion of body fat, which means that lipophilic drugs tend to stick into the body fat, so they're there longer. I.e. issues with Ambien, lower body surface area, smaller muscle mass, smaller organ size, lower glomerular filtration rate, changes in pharmacokinetics with the menstrual cycle based on hormonal levels. So we know that there are multiple factors that influence how drugs are processed. Unfortunately, almost all of the drugs that we have out there were tested primarily in men. And so what happens when the drugs get into the marketplace? Well, then we have women either being overdosed, women having unintended side effects. There was a study in 2000 where they looked at the drugs that were removed from the market because of unanticipated side effects. 8 out of the 10 were removed because of unanticipated side effects in women, again, because it's primarily tested in men. The sex differences in diabetes mellitus. There are women with diabetes have a higher cardiovascular risk than do women without diabetes, but a higher cardiovascular risk than men with diabetes have a higher risk of myocardial infarction and stroke. This is especially important for women as they enter menopause, because then you have the double impact of diabetes and lower hormonal levels, leading to increased risk of myocardial infarction and stroke. Differences in myocardial infarction in general. Women tend to present with different symptoms. Men tend to have the classic crushing substernal chest pain. Women tend to have fatigue, nausea, and shortness of breath. That's often unrecognized. Those are referred to as atypical symptoms. I would posit that they're atypical for men. They're not atypical for women. But because they're unusual or atypical, or people aren't trained to recognize those symptoms, women tend to have worse outcomes when they present with myocardial infarction, and tend to have higher morbidity and mortality both within the hospital and after discharge. Osteoarthritis, so in my area of orthopedics, significantly higher prevalence in women than in men, especially after menopause. Osteoarthritis, I think, is another condition of menopause that's often not considered. Typically, when we think of menopause, we think of the lack of ability to have children, but it's more than that. It's increased risk of osteoporosis, osteoarthritis, chronic pain, myocardial infarction, all of these other diseases that are linked with menopause, and again, beyond only the ability to have children. Not only are women more likely to have osteoarthritis at every joint that's ever been assessed, especially post-menopause, they're more likely to have other health conditions. Although men also have other health conditions if they have osteoarthritis, women are more likely to have these other conditions, and they're more likely to have more of them, and the prevalence of each of them is higher. Women also have an increased risk of myocardial infarction if they have OA than do men. And it's more than only the lack of ability to exercise because of joint pain. It's actually probably an inflammatory component that impacts both the joints and the heart. Women, especially postmenopause, are more likely to have chronic pain. The graph on the right was a study in which they looked at studies of pain, and every study where you see a blue bar indicates a study in which women were shown to have higher rates of chronic pain than do men. So chronic pain is a condition primarily of women. It's primarily a condition of women after menopause. This is impacted by both sex and gender. There are sex-based differences in how nociception is processed at both the brain and spinal cord level. There are also gender differences in that it may be more societally acceptable for women to complain of pain, to ask for pain medication. There are also issues with self-efficacy and catastrophizing that both impact the pain experience, and especially something that you see among women. Women tend to have higher levels of pain catastrophizing and lower levels of self-efficacy, both of which can impact how they complain and how they present with pain, all of which has an impact on function, quality of life, and independence. And if you look at specific health conditions, women have higher reported levels of pain for every health condition than do men. So if we know that there are sex-based differences, are sex and gender consistently included in research, and are women included at sufficient numbers? I would say no, but this is getting more play. This was a headline in the Washington Post a couple of months ago, talking about the gaps in heart disease research, especially measuring levels of troponin to diagnose MI. What Dr. Regensteiner from University of Colorado and her lab found is that levels of troponin for women having MIs are lower than those of men. Yet women's levels are assessed based on a male database. So we may be missing a lot of women with MIs because we're using a database that was based on men. Women patients are also, the public are also starting to figure this out. You're hearing more and more about medical gaslighting, where women are seeking care and being told essentially it's all in their head. As you see on the circle comment on the bottom right, it's mostly because we don't have sufficient research that's looking at health based on sex or gender, then using then that research to be able to inform patient care, to be able to inform healthcare curricula, and to be able to train the next generation of researchers to know what it is that they should be looking at to understand what some of the questions are. So if you look at, again, cardiac disease is the #1 killer of both women and men. If you look at women, however, in cardiology clinical trials, in the largest clinical trials, women only accounted for less than a third of those participants in the study. So there were significant gaps based on the prevalence of the condition in women compared to the research that included women. If, however, even if you include enough women in research in studies, are we looking at the results based on sex or gender, and especially sex, since it's a little bit easier to define than is gender? Because even if you include enough women in research studies for conditions that affect both women and men, unless you're looking at differences based on either their sex or their gender, you're still not going to know how that condition presents differently. The study on the left looked at studies that published in 2016 in 6 major orthopedic journals, more than 700 studies, including about 24 million patients. About half of the patients included in the studies were women, but only about a third of the studies actually looked at differences based on sex. The study on the right was one that we published a couple of years ago that showed about the same thing, that about a third of studies look at differences based on sex, with no change over time and no change and no difference if you look at conditions that we know have a sex-based difference compared to those that don't. So essentially, if you don't look, you don't find. So why does this matter? Well, again, we need the data to be able to inform patient care. We need the data to be able to inform things such as clinical practice guidelines. This guideline came out in 2021 that talks about how to address pain. And what we found when we were looking at the studies that informed the guideline, almost none of them looked at sex-based differences. So you're looking at modalities to address pain, yet have no idea how those impact the patient sitting in front of you in the room. Again, getting to another common condition in women, heart disease, 2017 heart failure clinical practice guidelines from the American College of Cardiology and the American Heart Association. Less than 2% of the studies reported any female sex-specific cardiovascular risk factors, and those that did reported only those related to sex hormones, which again are important, but they're not the only thing. This is a clinical practice guideline in the physical therapy literature, showing it's not only a physician issue. In the physical therapy literature, looking at clinical practice guidelines to treat low back pain, obviously a very common problem. Only 5 of the 36 looked at sex gender differences, but only 1 included any difference that didn't relate to pregnancy. So again, how do these guidelines affect patient care? But again, it's harder to develop guidelines unless you have data. So how do we achieve personalized medicine? How do we actually get data that helps us address an individual patient and tailor that data? Because unless we have research that looks at sex and ideally events at some point gender differences, at the phases of study design, data collection, evaluation, and manuscript development and submission, we don't have the accurate and comprehensive data that we need to inform patient care guidelines and especially future research. If we don't know their differences, how do young researchers know that they're supposed to look for differences? So what is the role of AI? Can't AI help with this? If we have large databases, do larger databases help? Maybe, and I think it has a lot of potential. We just need to know what some of the limitations are. So are there knowledge gaps in women's health research? Yes, there are a lot of gaps in the research. But what are some of the gaps? Well, what do patients want to know? What do clinicians want to know? What are some of the demographic disparities? That was one of the discussions at the menopause meeting, is looking at menopause onset that varies based on race, but we don't have a good definition of what menopause is, because menopause is not a thing. It's not a finite endpoint that one day you're not in menopause and the next day you are. It's a continuum, but we don't have a phenotypic description of what menopause is. Is it symptoms? Is it lab values? And what then are some of the demographic disparities among different races? So how do we move forward with research in menopause if we don't have a good way to define it? Meaning, if we're going to use large databases, what information are we looking for? What are the symptoms that we're looking for? If we're looking at conditions that affect both women and men, what are the differences in symptoms? What are the differences that are based on gender? And can we disentangle age and sex-based influences? This was a large part of the discussion at the National Science Foundation meeting, because there's some things that are related to aging. There's some related to loss of hormones, but how do we disentangle the two? Because obviously hormone levels go down with age, but there are aging effects that happen absent any impact from hormones. So how do we disentangle the two? And there's a research team at Colorado that's trying to look at that, at least in terms of musculoskeletal function, but we need to understand that better. So lots of areas where we could potentially use AI in clinical research for women's health, menopause, and otherwise, looking at history of natural diseases, treatment utilization outcomes, safety surveillance of medications, et cetera, et cetera. So a lot of areas in which we could potentially use AI. So some of the benefits that we discussed is that you can look at databases, even databases that you didn't think would be important in this, such as pharmacy databases. Again, women process drugs differently than do men. The research primarily is how the drugs benefit men, not looking necessarily at the benefit, not consistently looking at the benefits and risk factors in women. So do pharmacy databases help? What other databases could we be using? And so there are lots of benefits of AI that we could look at databases that perhaps we didn't know that we could look at. Looking at large databases reduces the issue of being able to not recruit enough women to a clinical study, so you would have that information. This, though, I think to some degree is part of the concern and what we need to look at moving forward is, how are the questions designed? If the questions are appropriately designed to look at sex or gender, those could be then put into the questions being asked as we utilize AI. But who is developing the questions? Because again, there's every research study that we've looked at shows there are differences between women and men. But research doesn't consistently look for those differences. So if we don't know there's a difference, are the questions being designed to look for those differences, or are we going with an assumption that there aren't any differences because no one ever looked? And again, if you don't look, you don't find. Some of the concerns, though, with AI in the women's health community, and actually I was just in a meeting last night where we were talking about this again, is if algorithms are based on existing data, and that existing data has some bias in it because it's primarily looking at men, are the algorithms that are being developed to utilize AI going to perpetuate those biases? For example, there are differences in presentation in just about every health condition. Parkinson's disease, women are more likely to have rigidity. Women are more likely to have dyskinesias and depression. For concussion, women have headache and dizziness. Men have more cognitive symptoms. And we talked about the differences in presentation of myocardial infarction. So if women and men present differently, but yet most of the studies are based on either not looking for differences or the differences that men have, if you're using AI to assess databases, what symptoms or what other data are you looking at? And are we only continuing to propagate those biases? How will AI address area where there's lack of representative or disaggregated data? Again, if there's data that is just not disaggregated, how is it working with electronic health records? If you're looking at gendered issues, and EHR is not so great at gender. About 10% of genders noted in EHRs have been found to be inaccurate, either because people assumed that someone's gender reflected their sex, or patients, because of stigma, were afraid to mention that their gender was different or that gender is fluid. So we know there are differences from a gender perspective and up to 2/3 of those who are transgender having issues with their gender being accurately reflected in the EHR. If we're using international databases, gender has a significant impact on health conditions like pain. We know that pain is expressed differently and opioid use is different around the world because it's a social or gendered impact. So if we're using international databases, how do we take that into consideration? If we are looking at gender also affects interactions that patients have with their clinicians. So if you're using large language models to process clinical notes or clinical interactions, if there's a gendered impact on how the clinician interacts with the patient, how is that taken into account and how is that identified? So again, it gets back to the data out there is not, there's a lack of understanding of the impacts of sex. So can AI have an influence? Yes, being able to assess large databases, but who's asking the questions and identifying what the questions are and interpreting the data to make sure that we're not continuing to just propagate the biases that we currently have. So a lot of short and long-term research gaps and goals that we talked about at the meeting, identifying the roles of measurement technologies and the limits on these, especially who has access to them. So if we're talking about working with people in an underserved population or working on global research, does everybody have access to a wearable or to an app, et cetera? Can we eventually link EHR data with wearables and apps and making sure that it's patient-centric? Identifying and aggregating existing data repositories, that again includes things that probably wouldn't think about normally, would be things like pharmacy databases. Creating tools to explore and query the data, but making sure that there's an understanding of sex-based differences and the limitations in current knowledge and what those differences are, and are we looking for those? Defining specific phenotypes, especially for menopause. Creating interdisciplinary teams to work on this using AI, with making sure that those in the teams recognize that there are differences based on sex and gender, what those impacts are, and therefore how to ask the questions and how to interpret the data, and then ideally collect prospective longitudinal data. So I guess the question and promise is, can AI lead to a faster understanding of women's health, including menopause, and development of prevention, intervention, and treatment strategies? Or are the existing biases that we already have in the literature just going to be perpetuated because we're developing algorithms that don't consistently take sex-based differences into account? So just a promo for actually a meeting coming up, the one they had this past year, and a women's health meeting that I'm putting together for next year. So thank you very much. I appreciate the opportunity.
Well, that's great, Dr. Templeton. Thanks so much. As a result of the conference and having, a deep understanding of these issues amongst the attendees, did you see any sort of collaborations or alignments coming to the fore?
I did, and that's a great question, and that's why I appreciated how the meeting was set up. The meeting was organized such that about half of us were women's health / sex gender disease experts. The other half were the technology AI experts. And so I think it was, and that's the way most of the panels were set up, is that there are both sets of expertise on the panel. So I think a lot of raising awareness on both sides, I think from the technology people, the experts that were there, the AI people, understanding that it's not just putting together algorithms, but understanding what's feeding into that and making sure we're taking into consideration sex gender differences. I think from the women's health side, it's understanding the phenomenal promise that this has, as long as the questions are appropriately asked. And I think understanding of how many databases that there are out there that we could potentially have access to, as long as we're trying to make sure that they all harmonize.
Right. You had mentioned kind of what the young researcher should be considering. Would it mean more for the researcher to have a cohort that is all female by sex, or just a more balanced cohort?
More balanced, I think.
Okay.
Yeah. And the reason I bring up the young researchers is, again, without data consistently in the literature, when you're looking at educational curricula, this material is usually not there. It's very infrequent that you have a discussion of sex-based differences other than reproductive health. So that impacts the clinicians who are not hearing about it and how they then treat their patients. But also for the young researchers in the room, if they're not hearing that they should be looking for sex-based differences, and they don't have a mentor that's telling them to look for sex-based differences, then why would they know that they're supposed to look? And so that's where, and so then you have data that doesn't consistently look for sex differences. So that means that the curriculum doesn't tell them to do it, which means that they're not going to do it in their research. And this is just a vicious cycle where things just don't change. There's a lot of push now in some of the work that I'm doing to try to change this from a journal perspective to increase the requirements of journals. There is some impact from that. And actually, JAMA just published a very long instructions to authors about how to include sex and gender. But to some degree, by the time a manuscript gets to a journal, it's almost too late. Because if the authors, the investigators hadn't considered the inclusion of sex in the study design and data analysis, a journal really doesn't have the authority to tell them to go back and redo their study. So that's why it's getting to the young researchers early on before they even start. So it is included, not later on down the road having a journal tell them it can't be published.
That's interesting. I see that Sherry has her hand raised. Sherry?
Yes, I wanted to find out, would there be a system that creates protocols to address some of the things that were just mentioned?
So a system to create protocols, that's at a variety of different levels. At least if you're looking at clinical research, it's looking at things like funding agencies. So the NIH has their sex as a biologic variable policy, which states they won't fund anything in which study proposals that are looking at studies of vertebrates or humans doesn't include mention of how sex is going to be included in the study. It's looking at the level for clinical research, IRBs and IACUCs, if they're going to undergo a study approval process. We've been pushing to try to get them more engaged because to some degree, this is an ethical issue that you need to be doing studies where the study population and the results actually impact the larger population involved. So that, and again, the journals are becoming increasingly involved with this.
So I guess I'm mentioning, not to interrupt you, I'm mentioning it as an opportunity for this group to endorse and then create keys or things to prevent these biases from disrupting the research and these systems that are, going to be with us in the future.
No, I think that would be an awesome opportunity. I think it would be a great idea. I think part of the protocol, if we're going to develop a protocol on this, is if you're using AI or any other similar technology to do a study of a condition that impacts both women and men, you need to have someone either as a mentor, someone on the research team, someone as a consultant who understands sex gender differences so that the question can be tailored appropriately and that the result that comes from the study or the answer that you get actually somehow makes sense so that it's not just a one-off and we don't understand why. And that's part of where we are now with the sex gender differences is we have lots of data on looking at incidence and prevalence. What we're trying to figure out now is the why. Because if you don't know the why, it's going to be really hard to look at prevention and intervention strategies. So I think having someone there that understands this on the research team so that you can look at the results and make sure that the results somehow have an explanation. And it's not just a piece of data that came out that actually clinically doesn't really help us all that much.
Thanks, Sherry. John.
Thank you very much, Dr. Templeton. This has been fascinating. For just one quick question, what's a good way, maybe you could put it in the chat for us to follow the activity, the progress of this committee going forward. It sounds like your job is not done. And so I anticipate there will be a lot more developments and meetings and so on to follow. But I do have another question, somewhat more general question. You mentioned that the EHR data is not that reliable when it comes to sex versus gender, which is a common problem in the research databases that you said as well. I guess what I want to get at is, well, in the back of my mind is what is the possible research value? What new value for research purposes would a really nationwide system of personal health records provide to the research community, the research enterprise? And it sounds like it might be, given that one has to assume that a personal health record gets some further additional attention on a curational effort to standardize the data in it, that it could possibly address that problem in the real world data world, so that when a participant is recruited or is being screened for a trial, they would have standardized, reliable real world data, including the data that you're talking about is not just missing, but is unreliable. Would you agree with that? And
Yeah.
Could I invite you to simply dream a little bit about how a nationwide system of personal health records would improve some of the problems you're talking about?
No, I think that's a great point and a great idea. I think part of the issue with gender is the stigma. And so unless someone is cisgender, they may be reluctant to tell someone what their gender is. And so I think either remove the societal stigma, which is going to take a long time, but if there is a way that patients have access to the records and they can put in their own gender, let them put in their sex at birth and their gender, allow them to do that so they're not facing the stigma of someone asking, or a clinician not feeling comfortable asking, or again, not understanding the tremendous impacts that gender has on health, and so not realizing that they're supposed to ask. I think the thing that concerns me the most when you look at the studies of the reliability of EHR, if gender is inaccurate in 10% of the cases, that's mostly going to be cisgender people. So even with cisgender people, we can't always get the gender right. So if there is a way that patients could have access to their own data and put that in for themselves, also understanding that gender can be fluid, so change it if it needs to be changed, or have other options for them to be able to put in gender. And it's important, again, because gender has such a significant impact on health because of the ability to access resources, et cetera. Even getting to something like pain, which is the most common cause of disability in the US and around the world, that has there's a huge impact of gender on pain. But if we're going to research that and we don't have that data point, it's going to be hard to know what that impact is. And so again, everything is both sex and gender. Sex is easier to put in the record, but it's the gender that can be the hangup.
Okay.
Gender is also the problem, though, with research, because it can be fluid. So is someone the same gender when they started the study or the start of the data collection period as they were at the end of the collection period? Small minority patients where that's going to change, but it's still, if you have a huge database, it's not going to be an insignificant number of people. So that's where I would say if people could input, if there's a way they could input some of their own data, that would be useful.
Yeah, well, good. Could I just one quick follow-up question? As you may know, there's a growing movement toward clinical research at the point of care. That there's a lot of discussion and debate about what kind of research could be done, at points of care. But in any event, there's a very strong movement to do it in part to solve health disparity problems, but also disparity problems with research participants. But it appears that maybe one of the first steps in that direction that could go to scale, at least, would be the collection on a routine basis by doctors, by not researchers, but by doctors in their EHR or in some form of additional data that is beyond what is just needed for routine care of the patients. In other words, a protocol of just some additional data collection. And it sounds like there might be well, I guess that's my question, but it sounds like there might be a need for additional data oops, sorry. There might be a need for additional data on a routine basis for women. That is not normally part of care, but would serve some of these additional needs that you're speaking about for including research and screening women for research participation.
Yeah, no, I agree. But I think the first step in that is working with them either when they're a medical student or resident, or when they're through continuing medical education, to reinforce why that data needs to be collected, because clinicians are already incredibly busy. Asking them to do one more thing is it's either not going to happen or it's not going to happen well.
Well, there would have to be a monetary dimension to that, but even so, that doesn't help the workflow problem. I mean, right. I realize that. So is KU med school instigating those kinds of educational services for the curriculum?
Well, that's why that was the not so subtle promo for the Women's Health Symposium for next year. I started our first one in May. We're having the next one next year. The focus of these is everything other than reproductive health. So we've talked about foot pain, and we've talked about liver disease, cardiac disease, concussions, the whole gamut of things that isn't reproductive health, to get the point across that women are more than just men with different reproductive organs. And so it's that education effort. I also recently received a grant from the Bill and Melinda Gates Foundation to develop an international online digital repository of education material on this.
Oh, great.
I actually have a meeting with them right after we finish this.
Excellent.
Well, that's great.
Thank you very much.
Thank you. Appreciate that.
I saw a few hands up. Josh, do you have a question?
Sure. Just the context for my question is I'm a recovering chief health information officer from the academic integrated healthcare side. And for the providers, physicians, clinicians listening, kind of keying off what John just asked is, how do we change the culture and make it safer to share this data? Because I can tell you in the context, and I have to be very careful how I phrase it because I'm in a policy role, but how do we frame it in a way that is more palatable for sharing? Because I think we're not even getting what we're asking already. So reaching further, I like where John is going, but it strikes me that we're overtasked and we're not getting satisfaction on gender and sex all the time anyway.
Right. Yeah, so I agree. As John mentioned, maybe it's reimbursement to some degree, but that's still, you can still get reimbursed and not have accurate data because you just don't have time to do that. So it is a workflow issue. So I wouldn't probably not put it in the role of the primary healthcare provider, non-physician practitioner or physician, whoever's doing the main work of the appointment with the patient. I wouldn't necessarily task them with this, other than having them understand the patient's sex or gender so they can help interpret what's going on in the visit, understand some of the laboratory work, etc. But I'm not sure I would task them with doing the data entry, because that's with the workflow, that's not going to happen. So whether patients can enter it themselves, which would be awesome, or someone else in the office enters it for them, that'd be great, but somehow get it off of that person to do that. In terms of data sharing, yes, there's a lot of concern, especially in the transgender community, about data sharing and where that data is going to go. I'm working with a group at Harvard now on developing protocols for that. How do we do research for those in the transgender community to assure them that their data is going to be safe? That's a huge issue. And that's part of the issue with the 2/3 of transgender patients having an incorrect gender in the electronic healthcare record. Not entirely that someone didn't ask, but people being, again, because of stigma, afraid of sharing because they're afraid of where that data is going to go. And so that's an area where we need a lot of work to make sure the data is protected. Otherwise, we're never going to progress research in that area. But again, I'm working with the people at Harvard, and we have a protocol that should be coming down the pike fairly soon to at least help inform researchers on ways in which data can be protected.
Thank you.
Thanks, Josh. Let's sneak in one more question. Derek? You're muted, Derek.
Glad one of us is paying attention. Thank you very much, John. Can you hear me okay now?
Yes, you're good.
Okay. And thank you, Dr. Templeton. I was late for the introductions. My question is related to the way that the meeting was set up, Dr. Templeton, when you talked about the clinicians on one side and the technologists on the other, which I think is a very good way to do it. And my question is this: we know that with AI, and when we consider the AI models in the training phase, when the models are being fed with the data set, which is critically important, as you pointed out, to make sure that the data is correct. Because now we're going into the inference phase, where now the models are starting to make conclusions. They're starting to give outputs. So, garbage in, garbage out, that sort of a thing. I'm interested to know, did the technologist have any construct, if you will, even the contours of a construct, about how we being you all, how we could, safeguard and make sure that the data sets are correct from the beginning? Because these are large volumes of data, as you well know, that sort of a thing, as opposed to moving full steam ahead into the inference phase, knowing that we're going to get a faulty output of data. And then a couple of the things that were raised, John Birch raised one of them, and then Josh raised it too, with regard to, hey, we want to make sure we get the data in. How do we do that? We want to make sure that we're not overloading the clinician at that particular touch point. And I'm just interested to know, was there any conversation or insight offered around that?
No, great question. And actually, in the AI and women's health conference call I had last night, that was exactly the phrase that was used: garbage in, garbage out. So I think at this point it is looking at the data sets, but I think even more importantly, looking at the algorithms that are being developed and making sure that the algorithms are actually not biased and they're using accurate information. And so if there are areas where we don't know the sex-based difference, then that maybe we need to look at that first before we try to develop an algorithm to look at large data sets. And how to overcome this, again, from the meeting, the primary discussion was making sure that you have someone as part of the team that's developing this, that understands sex gender, that can help in developing the algorithms. In terms of the quality of the databases at this point, I think that's something that's going to need to be addressed while things can, I think they're going to have to move in tandem. We can address how to improve the databases while the studies are going on, and gradually the information is going to get better. I don't think we can stop the train at this point to try to figure out how we make the EHRs more accurate, because we haven't figured out, other than, again, if people can input their own data, we don't have a way of doing that at this point. So I'm not sure that we can stop the AI train until that happens, but hopefully we can do both at the same time, develop algorithms based on the information and research that we have, and making them non-biased and taking into consideration how women are different than men, while we're trying to address how to make the EHR better.
Thank you
That's
very
great.
much.
Thank you, Derek.
Thank you. Thank you.
Dr. Templeton, that was really a very engaging and enlightening presentation. We really appreciate it. I think you can see from the interest of the questions asked that people are really starting to pay attention to this area, and thank you for bringing it to us. It's that important, so we're very grateful.
Well, thank you so much. I really appreciate the opportunity. If there is interest in moving forward with some statement or something from this group, please let me know. I'm happy to help however I can. The NSF, last time I checked it, it's not produced their report based on this yet, but I will circulate that once I have access to it.
Great. Thank you so much.
All right. Thank you.
Okay, let's switch tracks a little bit here. Dr. Mariah Kranz is with us to explain sort of a bit of her frustration over the lack of data sharing in maternal and child health and her efforts to try to address that. She's really taken a lot upon herself and her collaborators to try to change the scene. And so I'd like to invite Mariah to go ahead and tell us all about it.
Hey, thank you, John. I'm going to share my screen really quick,
Okay.
and I hope that it pulls up okay. Can you guys see that okay?
Yes.
Okay. So I'm going to talk a little bit about the community side of why we need to have things like data sharing, why sometimes the technological reach on the community or user end side is confusing and not available to us, or we just don't necessarily understand what's possible. And so part of the reason that we developed our data sharing network is because of those frustrations from the community and end user side of data and accessing data in healthcare. As I said in the introductions, I'm a program director here at Community Health Council of Wyandotte County. And one of those roles that I have is overseeing Cradle Kansas City, which is a maternal health collective impact initiative. And as a part of that initiative, the data sharing network developed and came as a part of that. So I'm going to give a little bit of background about Cradle and then go into the desire to create this network. So Cradle is a systems change collective impact initiative focused on maternal and child health, specifically that preconception, prenatal, and then postpartum up to about age 5 period. We're really looking at how do we change and address the policies and procedures that are strongly held, but maybe wrong, wrong for today's society, wrong for today's healthcare needs, wrong for the community in general, and wrong for specific communities. There's a couple of core tenets that we have at Cradle, and those include hope, joy, action, and clarity. A lot of this work centers around maternal and infant and fetal mortality, which is very difficult and very sad work, very challenging work and topics to address and talk about. But they do provide an insight into what's happening for some of the most vulnerable individuals residing within the U.S., within any country in the world. We know that maternal and infant health is for lack of a better term, the canary in the coal mine when it comes to how a country is doing in terms of health. So we really understood that data is needed, and we all want to do things that really feel good, but data sharing and collection doesn't feel good. It doesn't have immediate action. You don't have an immediate result from it. We can give out pack and plays all day long and car seats to keep infants safe, but that doesn't really change the end of what's happening and why they're happening, whether it's the social drivers, whether it's system failures, whether it's a desire. There's all kinds of reasons why those immediate feel-good actions don't actually do very good in the long run. And so one of the things that the collective wanted was to really look at data and how we share data as maternal health professionals, and how we talk about data and share data and the accessibility of data for community and for professionals across the board. So as a collective, we came up with some strategies of what we want to focus on and how we want to do this work. Data and information sharing was the #1 strategy that they wanted. It is so needed in this landscape, in any health landscape. It is very much needed. One of the key problems we have with data and information accessibility is that when you get data, let's say most of us get data on the community side from the state or the federal government when it comes to health data, it is old, outdated, aggregated incorrectly, and not comparable from state to state. Missouri and Kansas do not collect maternal and infant and child health data on the same time frame. Early childhood in one state is considered early childhood in a different state. One is 0 to 5, one is 1 to 6. That causes a problem in comparability of data and accessibility of data. We also know that how the data is aggregated together, we'll take maternal death, for instance, is usually grouped in 4 to 5 year groupings and reported usually 4 to 5 years after the fact. So for example, in Kansas, the most recent maternal death data goes from 2015 to 2020. That is not relevant for today. We cannot create programs, we cannot have focused initiatives, we cannot have focused interventions if our data is 5 years old. The problems that we faced from maternal and infant death 5 years ago is different today due to new healthcare crises, due to economic factors, due to new protocols in healthcare in general, and new technology. We know things like hemorrhage tracking have changed, yet our ability to access hemorrhage-related deaths hasn't gotten better, it hasn't improved. Not to mention those 5-year aggregate data that you get in those maternal and infant death ranges, they are not disaggregated. They're not disaggregated by race. They're not disaggregated by county. They're not disaggregated by city. And some of that is due to the numbers of them. I understand they're sensitive data. They might not be able to release that. However, I can get better data by Googling individuals' obituaries related to infant death, pregnancy death, death during a prenatal period, death in postpartum than I can from any available state or federal database. And that is sad. I cannot tell my community health workers or my team, my policy team, my health insurance team accurately how many families in our region have health insurance, how many families in our region need home visiting services or have them, how many there even are, how many agencies provide health insurance assistance, how many agencies provide home visiting, how many agencies provide early childhood education, because there's no one central location for that information within the Kansas City region, which is 8 counties and 2 states. That is a difficult barrier to cross when we're talking about county lines and state lines. And so one of the things that our collective, which consists of about 150 different individuals and an average of about 50 to 60 different organizations, depending on the year, came up with indicators they wanted to track, which are very community centric. I'm going to tell you, they're not, if you read them, they're not based the way that researchers or academics or clinical individuals are used to seeing, because it also has to be community focused. Our community members need to be able to see how many people have access to food, how many individuals are in home visiting, if there's a wait list for different home visiting groups. And so they came up with these indicators. They originally had over 200. We got them down to about 150, which is still too many, but they're also specific to certain areas. So the indicators or the variables they wanted to collect on home visiting, for example, are things that a clinician isn't going to report because they don't collect and they don't do. So while there's a lot of variables, they are within different subcategories for different populations. We also realize that we need to have as close to real-time data as possible. And the real-time definition is going to vary based on your industry. We are expecting real-time to be within a year, which still is not ideal for certain situations and certain special social service needs. However, it is way better than what we can get right now, and it's a place to start. So if we can start with 1 year being considered close to real time, that's our goal, and hopefully it improves, and it would be wonderful if we can get further than that. And so when we started in 2018 and 2019, I do need to preface this with, I am not a data sharing expert. I am not a tech expert. My background is all public health, community health, creating and developing initiatives and programs, and community engagement. So not knowing what some of these are, I Googled and I put together these documents. We got our 2-page, which is right here. I'm not sure if you can see them. They say draft on them at the upper right-hand corner. Our 2-page data agreement passed a set of hospital lawyers who signed on and agreed to share data initially. I don't know how that happened, but it did. It passed their muster, and it also passed the muster of 6 other organizations to share data as well. We put together, or I should say, I put together a 1-pager, which is in the middle, which indicates why we're doing this, what the purpose is. And again, I do not have a background in this, so I recognize it's pretty rudimentary, but it did what it needed to do to get the initial partners engaged. We have our community agreement, which is on the left, which identifies why we're doing this work and asking people to sign on and to join us. And then across the bottom is the 6 pages of key indicators or variables, the metrics that we wanted to track. Again, they are written in a way that is very community-centric. This is exactly how the community wanted them written. And when I say community, I mean a mixture of individuals from the community, residents from the counties that we serve, which is all 8 counties, professionals in healthcare, professionals in research, and also maternal health professionals, which include anything from home visitors to community health workers to car seat installation technicians, lactation professionals, and physicians as well. So our timeline for this work was we started identifying what was needed in 2018, and data sharing was the #1 priority. I developed the network in 2019. We developed with 7 organizations sharing data. And because, again, I'm very new at this and we had no money to do this, we just did it. There was a need. And so we did our best to meet the need. Everything was stored in a locked file on my desktop computer in my office that never leaves my office. I understand not the safest way to do it. This was also all de-identified data. So there's no way to track back to the individual. And after we had enough partners sharing, at the time, the idea was to move everything into a red cap so that it would be accessible for researchers and accessible for analysis. 2020 came. We had those partnerships solidified. We started to get more data being shared with us. Not enough to share out with the community yet, but it was coming in very early 2020. And then as we all know what happened in 2020, COVID paused everything. So we kind of put things on the back burner until we had more interest in things were stabilized in the social service space for response to COVID. So in 2021, all of our partners are deep in COVID response. We did pause expanding the network. We paused asking for additional data because individuals and organizations had things that they needed to focus on that were more important. In 2023, we started to invigorate the data sharing network internally. The discussions with my team and I, with our leadership and our board, moved towards let's see where this can go if we can actually get some solid funding. So we started to talk to partners and to funders regionally about funding this work at some of the policy conferences that I attend and some of the other meetings, systems change meetings and public health meetings that I attend nationally. Data sharing is becoming a more common and prevalent topic, and I started to research and learn more about the Gravity Project and the work that they're doing and identify how some of that work could help with the underpinnings of what we're trying to do. Again, at this time, it's just me. I do not have a background in this, and it's not my only role. So the development is a little slow, but it has come about naturally due to the need for this in the maternal health space. This year in 2024, those conversations really were revitalized, having more conversations with higher level partners, developed our partnership with a technical institute, Abada Health, and Alrock is on the call today and can help to answer any of those technical questions that I will not be able to answer. And we have been able to secure significant funding, multi-year funding for this network to get it off the ground. It is important to note this funding is grant funding. It is not venture capital funding. This is a nonprofit-based project that has to remain community-centric and community-owned. We intentionally are not working within academia or medical center for this network. And there's a couple of reasons why. The first is there's a huge distrust of those institutions in the community, and community-based organizations often feel when they partner with academic or medical institutions, they receive limited support, limited technical assistance, and the data and information that they are creating or the intellectual property they're creating as an organization is absorbed by that medical or academic institution and is no longer their own. And so that's the first reason why this cannot be centered in medical or academia. The second reason why, which some of you may know and experience, is that academic and medical centers don't like to share data and information with each other. And so in order to prevent those barriers, in order to prevent institution A from saying, I'm not going to join your network if it's stored at institution B, we really kept it out of those institutions and are keeping it in the community. We also recognize as this grows and as this develops, Community Health Council and Cradle may not be the right place for it long term. We also recognize that I myself may not be the right person to lead this long term. However, getting it started, getting it off the ground, and frankly, the tenacity and ability to hear the word no really does need to happen at this point. And so I think that does make our organization best suited to start this and launch this, and then we'll see what happens and where it goes beyond that. Our expectation for 2025 is really to get this cloud-based portal launched where institutions can upload their data or transfer their data over to get those customized templates developed for organizations of what data they're going to be sharing and what that's going to look like. And then also start to develop that dashboard that has the community-facing information so that anybody can log in and see in a general topic area what is happening in their region, and as drill down as small as we can, ideally be census tract, but we're just going to hope for county and city first in the beginning. And also recognizing that once we have this developed and created, maternal health is not where it has to stop. Once we have that blueprint, it could easily be translated to other health topics, as long as they have a community-centric focus. Meaning, if you're going to do this in, let's say, heart disease, how is it going to be accessible information and relevant information for the community, for researchers, for organizations who work on heart disease, for institutions like the YMCA who have silver sneakers programs? How can they utilize that information? It's really important that this network and the blueprint, as it may develop and for other health topic areas, remains true to the need, which is this is community-centric information that we all need. Researchers can benefit from, medical can benefit from, but also social service agencies and community members themselves can benefit from and get an understanding of what's going on in their region or area. We are in early stages, like I've said. Again, Anurag can speak to any of those technical aspects or questions that you may have that I cannot answer. But I do want to just share briefly some of our partners that we have. Abada Health is the technological partner. Health Forward and Reach are our funding partners. We do have, like I said, a hospital, but I have committed to not sharing that hospital name until we have additional hospitals sharing information. And part of that is to, one, protect their privacy, and two, if this information was shared, you would know exactly what institution it is. And we want to make sure that they have the ability to really develop how they're going to get that information and hone it in and finalize it for us. One really amazing side effect from this work is in 2019 and 2020, when I shared these indicators and I shared this work with this medical institution, they recognized they couldn't even collect and report some of the information internally for their own needs. And so they were getting ready to onboard a new EHR, and they actually changed how they collect information in that EHR when it comes to maternal child indicators. That way they could tell themselves how they were performing in some of these areas. So that was a really amazing side effect, is to have them change how they did their own data collection, and then now how that's getting to us. And because this is maternal health, includes social services, we have entities like Start at Zero, who is the home visiting parents as teachers agency. We do have Happy Bottoms, who share, they provide diapers for families across the metro. They're sharing information. That's also important information to know. How many families can't afford diapers and are relying on them for support? The Kansas Breastfeeding Coalition shares information about breastfeeding resources and breastfeeding data for the state of Kansas. Vibrant Health is one of our partners for sharing information. There are a federally qualified health center that do provide prenatal care. They provide a lot of prenatal care here in the Wyandotte County area. And then BioNexus is a partner in terms of some technical assistance and support, and then also just believing and committing for the need for data sharing and wanting to support this work as well. There are a couple ways that individuals on this call or your agencies or organizations could get involved. One is, if you're interested in sharing information with us or learning more about sharing your information and what that may look like, let's talk about signing up or talk about developing that. Community agreements, we always are looking to grow the collective and looking to grow people who want to be engaged in this type of community-based systems change work. Individuals and organizations can join. You can and also community members can join, and we want to make sure it's open and accessible to everybody. And then also joining our efforts in terms of this data sharing network. We do have an opportunity for individuals to join our steering committee for the data sharing network, and then also technical assistance and support or ideas. If you just want to support the effort, you're more than welcome to join those conversations. This is all moving forward faster than it has before due to the funding. Now we can really pursue this in a more official format. but we would love to have individuals who have experiences in data analysis, in data sharing, in informatics, and also in community-based support and collection and medical supporting this work. And to reach out to us, there's my contact information along with HonorRock, and I'm happy to answer any questions that you may have at this time. And if they're technical, HonorRock can unmute and answer those.
Okay, thank you, Mariah. A couple of questions. The first is, you started out with Cradle KC as your base. How many organizations are involved in Cradle KC?
So roughly we have 156 to 60 individuals and about 50 different organizations. And that wanes depending on the time of year, depending on, people change roles, and also recognizing that during COVID, a lot of people in this maternal health social service space left the organization or moved or changed roles. And so there is a little bit of a decrease right now in individual participation, but we still have about 50 to 60 organizations that are committed to the work.
Okay, great. We really saw this presentation this morning as an extension of what we've already initiated with paying attention to maternal and child health. And you were gracious enough to be part of our forum on that topic. You had mentioned at that time that there are some challenges in pulling this together. For instance, you had mentioned coming to an agreement on what is HIPAA protected and what is not. Can you share a little bit more about that, the kind of the challenges that you run into?
Yeah, so that is one of the big issues that we had initially in discussing the data network, and concerns people had when they wanted to form this initially. In the medical field and in the data science field, there isn't so much confusion on what is considered HIPAA or PHI or what can be shared. But in that social service or community health service space, there's a lot of concern and a lot of confusion. One of the biggest concerns that was brought up was proprietary information. Well, in the spirit of actually sharing data back and forth, that's not, you don't share proprietary, you don't share how your program works or sharing how many people you serve. But there is some misunderstanding that the actual number of people that you serve or your waiting list numbers is proprietary. And so there will be ongoing needs of discussions to understand what is considered proprietary information and what isn't, what is considered PHI or HIPAA protected and what isn't. Things like zip code, things like age of the patient, not the birth date, but the age of the patient is a challenge. And then also looking at, as this data sharing networks grows, do we need to be receiving information that is identified so we can link records and not have duplications, and then de-identify it for the public facing side? What does that look like? Is that something that we need to do down the road? And as you know, HonorRock I've had those conversations, and it's looking more like we may need to have identified information shared going forward as we develop this, and being able to de-identify that within the system itself so that no one sees, no one has access to that, but that way we don't have duplication of records. But there is just a misunderstanding in general of what is considered protected and what isn't. And that is going to require a knowledge campaign for the community-based organizations and for community members.
That's interesting. Any questions from the group? John Birch.
Yes, Mariah, you mentioned that one of the key components of this is community use of the data. Would you be able to describe in general terms and the various categories of use that would fall under that umbrella? And I understand that that's a HIPAA issue, and that's, if I understand what you just said, that's perhaps one of the sorest spots in terms of HIPAA and privacy rights to the data. But in any event, what are those uses that you're referring to that are essentially community uses?
So when I say community uses, I mean two different groups: one, community-based organizations, and community members. As a community-based organization, we have team members who work with families of all kinds, of all ages. And it's very difficult for them to understand why a family is being told there's a wait list for a home visiting program over here. But when you talk to the actual home visiting program, they say there isn't a wait list. In the referral networks, they say there is a wait list. And when you talk to one of their case managers, they say there's a wait list, but the organization head says there isn't. So there's some confusion there. So what does that look like? So then how can community-based organizations see in real time how many people are being served in home visiting? For example, for community members, we have a big disconnect on the issue and challenge of maternal and infant mortality. If you ask your average person in Kansas City, is there an infant mortality problem in Kansas City? Most people are going to say, what is infant mortality? What does that mean? And no, there's not. In reality, we lose an average of 6.5 kindergarten classrooms worth of children every year due to infant mortality, fetal and infant mortality. These are non-homicides. This does not include abortion. These are infants and fetal deaths that occur due to genetic complications, due to health conditions, due to prematurity, due to low birth weight, due to infections, due to a number of reasons that are not necessarily preventable. A lot of them are preventable if we look at changing how the system functions. But when we talk about in the moment, in the fact, there are things that we can't prevent. We can't prevent genetic abnormalities, for example. But people don't understand what the actual problem is. And it's not going to impact the majority of people. But when we see and we hear that there is over 100 maternal health organizations in Kansas City, for example, a lot of them focus in specific geographic areas, but those are not the only areas that we have, say, high infant death rate. There's a zip code in Olathe that has a very high infant death rate that is actually higher than most of those zip codes in Kansas City, Missouri, and Kansas City, Kansas that are the most worrisome. Yet there is nothing being done. There is no review board reviewing those deaths. There is no focused work in that area to address those infant deaths. I can't even tell you what the causes of deaths are. I can tell you that there's a large amount. So helping to see what's happening on that larger scale for community members who either want to know why they can't get into a program, want to know program capacity, want to know how many programs there are in a particular area, or for organizations who are trying to focus their work, understand what they need to do and where they need to serve, and to prevent that hyper-focus in one area with the neglect in another.
Well, I guess my question also involves, like, who is the user? What individual is sitting down at a computer and looking at someone's data from your database?
So they wouldn't be looking at individual level data. It'd be looking at a health topic area. So for example, infant mortality, or for example, places to get prenatal education at, or number of food banks that are being serving families. So it's not a referral network. That's not the intention. It's not to see where to go to get assistance. It's to see what's happening. Realistically, there's going to be very few community members who have an interest and want to do that and look at that dashboard. Community organizations are going to be some of your most focused groups utilizing it, a lot for their programmatic work. So when we're writing grants, we need to be able to say what's happening and how we're going to respond to that. Well, now community organizations can't do that realistically with real-time information. It's not possible. There isn't a lot of research in maternal health, as we know, in women's health, as we know, but definitely not a lot in that social service side or the non-clinical side of maternal health. This provides an opportunity for that as well.
Great.
Thank you,
John. Other questions?
So I have a question. This is great. I love hearing this stuff, but what are you doing in looking at going across agencies, how you're going to be able to define operationally the data that you're looking at? For instance, different agencies may define food insecurity in different ways.
Yeah.
So how are you going to put that data together to have, like a singular definition that you're going to work under? Is that what you're going to do?
Yes, so absolutely developing a code book. We do have a code book developed, and that will be refined as more organizations join and we have better definitions of what, say, food insecurity is. This is not to be a social driver of health database necessarily, but that may be an end result. It may produce that for the maternal health sector. That may be, you know, a really good offshoot that it creates. But there will be a defined code book of what terminology is that will be available to anybody. It'll be publicly available, so anyone can look. If they have a question what infant mortality is, it tells you. If you have a question about food insecurity, it tells you. You know, there will be some standardization required for REL data for race, ethnicity, language. And then as institutions are required to improve their SOGI data collection, that will also come on as some standard definitions. And, you know, hopefully it helps to change how some organizations collect that REL data. OMB standards have come out. They are going to be required by CMS moving forward. So we will see changes in how that's collected. So there will be some standards to begin with, but there will also need to be a refinement of definitions due to, like you said, people collect and report things differently, which is also another one of the problems and barriers that we face. And food security is a great example. Some people report food security or food insecurity if you've had trouble, you know, in the past year putting food on your table, and other organizations report it in the past 7 days. So it's a huge disconnect and a huge time frame difference. And so we will need to have standardized definitions, absolutely.
That's a great point. Any others, please? I have one, I guess, Mariah, and this maybe is more for Anurag, but where, from a technical standpoint, where do you see the data residing and who would be managing it?
So the data would be, I'm going to do my best to answer this, and Anurag, please jump in when I misspeak. The data will be residing in a cloud-based structure that'll be web-based. And analyzing the data will, you know, we're hoping to be able to bring on a data analyst person to analyze it. But at first, it'll be analyzed by our internal data person and myself.
Okay. This just seems like a great movement. And I'm so happy that you're doing it. Any other thoughts from the group before we close out today? Okay, well, Mariah, thank you so much. We've learned a lot. Your progress, you call it slow, but it seems to be very steady now, and we certainly appreciate your efforts in doing it. It's a great thing, and we hope that many of us in the community will be able to take advantage of the knowledge that this data sharing brings.
Thank you. Thank you for having me.
Thank you. And I'd like to wish everybody happy holidays, and we'll join again the last Wednesday of January. Also, please do not forget that this Monday we're having a forum in which we'll be discussing lessons learned from COVID. And we have health directors from both Kansas City, Missouri Health Department and Wyandotte County, as well as our own Aaron Deacon as panelists. And I invite you to go to our webpage on the events page and register for that. It'll be a great program. That's Monday night coming up. So again, happy holidays to everyone, and thanks so much. Bye now.